My name is Kendra Julian. I am the Adolescent Immunization Specialist for the Partnership for Maternal and Child Health of Northern New Jersey, which is providing today's program. I am joined today by Anal Patel, the Program Coordinator for Public Health Initiatives, and we will be moderating today's program. Just a few pieces of information before we get started. The planners and speakers have nothing to disclose. Within an hour after the presentation, you will receive an email with a link to a survey. Please complete the survey to provide us with feedback on the program. To receive a certificate of completion, you must listen to the entire webinar and complete the evaluation survey. Certificates of completion will be sent via email approximately a week after the webinar broadcast. This program is being recorded and will be available on the partnership's website until March 25th, 2023. We will be muting all attendees' microphones during the presentation, but we would love to hear from you. Please write your questions in the question box, and each speaker will respond to as many as possible at the conclusion of each presentation. Now I would like to introduce our first speaker, Dr. Jeffrey Greenstock. Dr. Jeffrey Greenstock is a board-certified pediatrician and has worked to improve the health of children in New Jersey and abroad for the past 25 years. He has been honored by the New Jersey chapter of the American Academy of Pediatrics as Pediatricians of the Year and has received the Childhood Immunization Award from the CDC. He's currently a pediatrician at Pediatri-Care Associates in Northern New Jersey. Welcome, Dr. Greenstock.
Thank you, Kendra, and thank you so much for that great introduction. And it's so nice to be here with the partnership. I've been on the board of trustees for many, many years. And though we've changed locations and we've changed executive directors, it's always nice to be part of a wonderful cause for the mothers and children within the state of New Jersey. And I'm very happy this afternoon to speak about HPV vaccination for the pediatric and adolescent population. Next slide, please. So some of our objectives for today will be to describe why HPV vaccination is important for cancer prevention, to identify appropriate HPV vaccination schedules based on patient ages, to describe effective HPV vaccination recommendations for patients age 11 or 12, as well as for those 13, 14, and older, to develop self-efficacious manners in delivering effective HPV vaccination recommendations, and to identify reassuring, confident, and very concise responses to the many, many parental questions that we hear about vaccinations, especially the HPV vaccination. Next slide. So before we get started in talking about HPV, which we really know is an illness that can be prevented by appropriate vaccination at appropriate ages, let's talk about hepatitis B vaccine, the vaccine which now prevents children, adolescents, and adults of all ages from contracting hepatitis B virus. I can remember not too many years ago when I finished my residency back in 1988, how we had this banter about HPV vaccine and how if we could give a vaccine for HPV illness, we would be able to prevent liver cirrhosis, liver failure, and hopefully liver cancer. With that as a premise, the HPV vaccine for human papillomavirus has been established as a great means to prevent infection for viruses which cause cervical cancer, and as you will hear later between myself and Dr. Joaquim, other cancers which children, adolescents, and adults potentially can contract. Next slide. We know that HPV types differ in their disease associations. There are some that affect the mucosal sites of infection and others that contract and affect the cutaneous sites or skin. When we talk about the most common or highest risk HPV serotypes, we talk about serotypes 16 and 18 being the most common. And we know that these can cause cervical cancer, as we've mentioned, anal genital cancers, oropharyngeal cancers, other cancer precursors, and even low-grade cervical diseases. For the most part, this is why many women will continue to see their gynecologist and have screening for cervical cancer. We know there are low-risk or non-oncogenic types of HPV, serotype 6 and 11, that can cause genital warts, laryngeal papillomas, and low-grade cervical disease. And then we know that there are probably around 80 types of HPV or human papillomaviruses that can cause skin and common skin warts on the hands and on the feet. Next slide. We've looked at some of the studies which have occurred on and before, and then shortly after the administration of HPV vaccination. And we've seen what some of the associated cancers have been. We know that from around 2008 until 2012, HPV-associated cancers were climbing rapidly to nearly 39,000 a year. Not a small number, but with the advent of the HPV vaccine, we were able to see these fall. So the number of cases in that 39,000 were approximately 1/3 or almost 12,000 cases of cervical cancer. About the same number, maybe even a little bit more, of oropharyngeal cancers in males, and upwards of 5,000 anal cancers, mostly in male, but yes, in females as well. We know that about 31,000 of these were all attributed, these cancers, to HPV, and about 29,000 were attributed to the preventable types of the vaccine, which we now use, which has 9 common serotypes. We'll get into why 9 became an important number, where 4 wasn't doing the trick, and even 2 were not doing the trick. Next slide, please. HPV vaccine and the burden of disease, we know that almost everybody will be infected with at least one type of HPV at some point in their life. Most individuals will not know that they've been infected. We know that this typically occurs during intimate sexual contact. Remember, intercourse is not necessary for infection. It's estimated that there are approximately 79 million Americans currently infected with HPV. As we've said, with new infections occurring every year now, and prior to HPV vaccination, we had about 350,000 people affected by warts every year. The most common age for HPV infection is in the late teen to early 20s. Next slide. How do we protect children? Well, as a pediatrician, most pediatricians know how important vaccine preventable illnesses are. Whether this is meningitis, hepatitis B, as we said, diphtheria, pertussis, tetanus, polio, influenza, meningitis, and now even we're protecting adults and children down to age 16 against COVID-19 or the SARS-CoV-2 virus. We know that the HPV vaccine helps protect against certain types of cancer. Like I said, HPV is very common. Cervical cancer in women, genital cancers like vaginal cancers in women or penile cancers in men, anal cancers or oral cancers like mouth, throat, and other head and neck cancers. Next slide. Here's a slide. It's a little busy, but it talks about males and females and the different serotypes that seem to affect. In the dark blue, we can see types 16 to 18. In the medium or almost sky blue, beautiful day today, temperature 75 degrees, crazy weather in the Northeast, especially New Jersey, but a nice blue sky with types 31, 33, 45, 53, and 58. All these are now part of the 9-valent vaccine that is commonly administered to teenagers from ages, or preteens from ages 11 onward to age 26. Other types of cancers and HPV negative. So while we know cervical cancer is primarily caused by serotypes 16 and 18, as I said previously, highly oncogenic, we know that there are other types of infections that can cause cervical cancer, vulva cancers, oropharynx cancers in males and in women. Next slide. So again, the most common cancers caused by HPV. Here's a breakdown of women versus men. Unfortunately, unable to find the ages for this, but we know as this is a vaccine preventable illness, these numbers will continue to fall. And you can see, while we talk presently about almost 21,000 cases of cancer in women, there are almost 15,000 cases in men. So when the vaccine first came out, I had mothers asking me, why do I need to give this vaccine to my son? Well, Mrs. Smith, where else do females get it but from males? And where do males sometimes get it? From other males or other females. So this is almost a bi-directional illness. But you can see how cancers of the throat, cancers of the rectal or anal areas, cancers of the penises are really something that we need to be worried about. And with the advent of the vaccine, as I said, we've seen this drop off dramatically. Next slide. Great. So we know that the HPV vaccination can prevent over 90% of cancers caused by HPV illness. Next slide. Again, here's a breakdown, pretty much saying a lot of what we've already heard before, but more than 9 out of every 10 cervical cancers are caused by HPV. I can't stress that enough. If we had other ways of preventing the other 1 in 10, we would be doing that. And this can all be prevented by HPV vaccination. And that is what we're talking about with this one shot or a series of shots now that children need to get as they go from ages 9 on to young adults to age 26. I often talk to parents about how important preventing HPV illnesses because of cervical cancer and throat cancer and anal rectal cancer. And I talk about how important it is to protect even breast cancer. If we had a vaccine for breast cancer, the line would probably be from one of my 5 locations down to the Meadowlands and back. People would be waiting online, but there seems to be a little bit of a stigma in cervical cancer being a HPV being a sex virus. Next slide. Vaccinating boys, I said, can prevent cancers caused by HPV in men. As I said, HPV does not only affect women. More than 40%, or 4 out of every 10 cases of cancer occur in men. Every year, as we said, almost 15,000 men get cancers caused by HPV. So whether you have a son or a daughter, you must speak with your doctor or the provider for your children about the importance of HPV and human papilloma virus vaccination. Next slide. Six reasons to get the HPV vaccination. Common, very common. 80% of people will be exposed at one point. Here's a summation of about 35,000 cases of cancer from HPV. Vaccination works. We know that since the vaccine was approved and used in the United States back in 2005, cancers have dropped dramatically, 86% in teenage girls. It's easier to prevent cancer than it is to treat it. This was one of the fights that we had initially with some of the insurance companies, getting them to pay for such an important vaccine. But we know that if we can prevent cancer, it's a lot cheaper than having somebody go through the treatment. And since we know many of the types of HPV are prevented by the vaccine, it's very important to vaccinate. We know the vaccine is safe, it's effective. There are good studies now showing that the vaccine is safe, effective, and provides long-lasting protection upwards of at least 10 to 15 years. Again, we don't have a lot of data much past that, but I can make the analogy to the SARS-CoV-2 vaccine for coronavirus. The data is what the data is. As more time will go by with both vaccines, COVID as well as HPV, we will see less illness, we will see less cancer, and fortunately, we will see less deaths. Vaccinating is quick, it's convenient. Many of these children, as I will talk about later, typically get this at their tween checkup, between 9 and 12 years of age, most commonly on their 11-year checkup as they're entering into pre-high school or into the middle years of high school, in middle school. Next slide. Dosing. So we really have one dosing schedule that pediatricians prefer. It's a 2-dose schedule, and we know if we start that in males and females prior to their 15th birthday, as early as 9 years of age, we give one shot at time 0 and the second shot 6 to 12 months later. If for some reason they get their second shot less than 5 months from their first shot, a 3rd dose will be required. So you can see one of these vaccines can be given on their checkup. The second one can be given 6 to 12 months later. If we go past 12 months, we have been told by the manufacturing companies and the CDC and the ACIP that it's okay to pick up the schedule where you left off. We don't need to go back to time 0 and start over again. Next slide. If, however, we start on or after the 15th birthday, we need to give 3 vaccines. For immunocompromised individuals, this would be males and females with autoimmune disease, cancer, HIV infection. 3 doses is recommended. We can go as far as 26 years of age. I have heard of people getting it past there off-label, not what I'm recommending, not what has been talked about in the package insert. But these individuals get their first shot at time 0, they come back 2 months later, and then they come back 4 months later or 6 months from their initial shot. Again, not onerous on a family, especially when you explain how important the vaccine is. Next slide. Here's a comparison of the 3 vaccines that have been out. The bivalent, again, shown in the middle with that light blue sky, talks about type 16 and 18. This was one of the initial vaccines called Cervarix. Fortunately, and I say fortunately, it's no longer available because it only had the 2 serotypes, 16 and 18. The initial vaccine that came out in 2005 was a quadrivalent, or the HPV 9. That Gardasil 9 included types 16 and 18, as well as a lower oncogenic serotype 6 and 11. Fortunately, that was replaced with the present 9-valent vaccine that we use, that we mentioned before, which includes the 5 other serotypes. Next slide. This is what they look like. Fortunately, like I said, we're only using that Gardasil 9 right now, and very effectively with much more faith by a lot of our parents. Some of this has been supported by the national media, and we'll go through some of that in a little bit. Next slide. Some of the hurdles to promoting the HPV vaccine. Next slide. Most parents will accept this, some will question. Parents question us a lot. We're getting inundated now by questions regarding the SARS-CoV-2 vaccine and when will this come down to the children and should my mother-in-law get it, et cetera, et cetera. Does my child need the HPV vaccine? Of course they do. what diseases are caused by HPV? I think everybody in the audience now could answer that question. How do you know the vaccine works? We've seen results. We've seen the number of cancers and the number of deaths really being driven down. Is my child really at risk for HPV? Anybody that is exposed in any way to sexual contact is at risk. Why do they need it at such an early age? We know that if we vaccinate early, the body accepts the vaccine better, as their body is sexually naive and really has a better response to the vaccine. Next slide. Most parents will accept HPV vaccination when I effectively recommend the vaccine, address their questions, and talk about how safe it has been for even all of our patients in the practice. I'm worried that my child will think that getting this vaccine makes it okay to have sex. Of course, that's never your child, it's always the other child. Why do boys need the HPV vaccine? I think the numbers that we showed previously kind of bear that out, and you'll hear a little bit later from Dr. Joaquin about that. Is the HPV vaccine safe? Yes. The only thing that we see in our office sometimes is that some of our adolescents seem to be a little lightheaded. So we would never give them a vaccine and then send them right out into their car to be vaccinated if they were not vaccinated earlier. But if they are with a parent, we'll have them sit in the office or sit in the office alone until they feel well enough, usually a hold time of between 12 and 15 minutes. We know the HPV vaccine does not cause infertility. And would you give HPV vaccine for your children, for your kids? I did. That speaks volumes. Next slide. It works. We have these numbers. We've seen a decrease in prevalence of the most dangerous and highly oncogenic strains. We're down significantly in females and all ages across the board. Next slide. We can talk about parents. This is something on the CDC website. That would be cdc.gov. And if you search for HPV, this is a great flyer to have available and for people to have handy. We can make this available to the audience if you guys need it. Next slide. Why are rates so low? I think some pediatricians just don't push the fact, and some parents decide not to vaccinate. Next slide. We need to be firm. When we communicate this during our visits, we need to present this as this is the time. Not really recommend it, this is the time. It's not a new vaccine anymore. We know that some parents are a little bit hesitant. We need to engage them and we need to communicate with them why all of this is important. Views that teens are not at risk could delay this. Well, again, we've already shown that if we vaccinate early, 2 vaccines, highly efficacious, and we can drop the rate of cancer. There are some pediatricians that have lack of knowledge. There are some healthcare providers that have lack of knowledge about HPV and the vaccine itself. Unfortunately, we have many less visits from age 9 through children going to college. Many parents will bring their children in once a year for a health maintenance physical. This is not like the number of visits that we see in the first 2 years of age when we're trying to get all those other vaccines in. Next slide. Evidence-based interventions. It improves the equality. We need to vaccinate. We need to decrease missed opportunities. And we need to improve completeness by compiling data. This is something that we look at in our office. And if a parent is past the date of coming in for their second, or if it's their 3rd vaccine, we will reach out to them. Next slide. We already showed this slide. I just figured it was so important to put up again for parents to see and for you all to see. Next slide. We need to foster a good vaccination policy in our offices. Parents need to be aware that healthcare providers do vaccinate. We need to make sure that parents understand the reasons why we provide immunizations. We need to make resources easy to find. We need to review the status on each and every visit and prepare our patients and our adolescents for vaccines on each visit. We need to make effective recommendations. Next slide. We need to answer all questions. We need to implement procedures and policy. My staff is always looking to make sure everybody is up to date. Scheduling return visits before they even leave the office. And like I said, even sending out reminders. There are certain apps now that have been used, provided by the manufacturer. Next slide. As I said, national media has been very supportive. Next slide. HPV sharply reduced in teenage girls following vaccines, study says. In Australia, they're almost at the point where they've been able to eliminate cervical cancer. Next slide. HPV vaccines are reducing infections, warts, and probably cancer. HPV vaccine is proving very, very successful. Next slide. Even a single dose has been shown to provide some protection. However, I would never put on one glove in the winter when I'm shoveling snow, one boot if I was walking for the rain, and I always put my seatbelt on. So complete your series. Next slide. I want to thank everybody. I want to remind everybody that during these serious times of cervical cancer, anal rectal cancer, HPV and effects, and the need to vaccinate, that we don't forget about SARS-CoV-2. If you haven't gotten your vaccine, get it. Don't forget to wear your mask. Don't forget to wash your hands. And the last W is watch your distance. Thank you all. Thank you to the partnership. We'll answer any questions. And if we have time, we can always go back over any concerns that anybody has. Thank you all again.
Thank you, Dr. Greenstock, for that informative presentation. Now we have time for questions from the audience. The question box is currently open, so please feel free to continue to submit your questions. So right now, all right. So, Dr. Greenstock, the first question I have for you is, why is it best to give HPV in early adolescence, so between ages 11 to 12?
Well, there's a couple of reasons. One, we tend to couple vaccines at that age. We know that children going on to middle school into 6th grade in New Jersey need to be boosted with their Tdap, which protects them against whooping cough or pertussis. They get their first meningitis vaccine for types A, W, Y, and C. And we also know that at that point, we can give that vaccine. It almost becomes a rehearsed slogan for me. So today, your child is getting their tetanus pertussis booster, their first HPV vaccine or Gardasil vaccine, and their first meningitis for A, C, W, and Y. And by the way, this is the best time to give it because the body seems to accept it and make a better response when their body is sexually naive before their first contact in an intimate relationship.
Thank you so much for that, that answer, the response. I have another question. Do you know of any legislation that would require HPV vaccination for middle and high schools? And do you think this would be beneficial?
This would be great. There are some states that are pushing that way. New York now is trying to put a law through. I know we're in New Jersey. Rhode Island is a state that is enforcing this. Now, Rhode Island is a state where vaccines are basically handed out by the state. This is not an insurance issue. I think it would be wonderful if we could. The state chapter of the American Academy of Pediatrics has spoken on this previously, and we're hoping that in the future, this will become as important and required the same way that hepatitis B or measles, mumps, and rubella vaccine is required for children entering into school.
Okay. And I have another question. Are there vaccination options for older adults that may not have had vaccination opportunities when they were younger?
So right now we know the date of vaccination, or the age for vaccination for human papillomavirus, is 9 to 26. Like I said, there probably are people that are getting it past that age. I remember many years ago, I was asked the doc in one of the local newspapers, and somebody said, well, I'm 27 years old and I heard about this vaccine. Can I get it? And I had to really say, at this point, it is not approved for individuals past their 26th birthday. Again, I think there probably will be some more studies that show that. The problem is, as we said earlier, many people by the age of 26 have probably been infected with at least one type. Again, there are still many types, as we said, of protection. It would be great to protect everybody the way we do for all vaccines.
Thank you. And I just have one more question before we wrap up your session. Is the HPV vaccination offered in pharmacies such as CVS for administration?
Yes, I believe in many of the pharmacies it is available now. In some states around the United States, there's been a push for pharmacists to vaccinate the way they vaccinated for tetanus or MMRs, or right now for SARS-CoV-2. But the big thing, or a flu vaccine, the big thing is making sure that those vaccines are entered into the registry. We don't want people getting more than they need. We want people to be vaccinated on time, effectively, in a safe manner.
Okay, and so just one more, sorry about that.
Why are you
sorry?
Stated earlier, I'm here for the duration.
You stated earlier that intercourse is not necessary for infection to occur. What other means can infection occur by? What other means can infection occur by?
We know that potentially with oral sex, the illness can be passed on. And again, I'm sure we're going to hear that from Dr. Joachim. And again, it all goes back to your description of what sex is. We know okay. Intimate contact could potentially lead to this, the same way other infections can be passed on.
Right. Well, thank you so much, Dr. Greenstock, and thank you to all those who submitted their questions. Now I will turn it over to Anal Patel. Thank you.
Thank you, Kendra. Hello, my name is Anal, and I would like to welcome Dr. Sam Joachim. Dr. Joachim is the Chief Dental Officer at Zafar Health and has a long career dedicated to making quality services and education accessible to the underserved. His mobile dental and school-based programs bring services and education to elementary schools, nonprofit agencies, farms, and other outlying locations where access to care is difficult. He is a graduate of UMDNJ and earned a master's degree in dental public health from UMDNJ School of Public Health. Welcome, Dr. Joachim.
Thank you so much. Thank you. A pleasure being with you this afternoon. If you could go ahead and move to the next slide, please. All right, so I wanted to share a project that we did at Zufall Health Center with you this afternoon, and just kind of describe the project we did, which involved using dental case managers for improving our HPV vaccine rates. Next slide, please. And we are a health center located in North Jersey. We actually have sites all over northern and central Jersey. We're a federally qualified health center, was started in 1990 as a free clinic, and became a federally qualified health center in 2006. We are a patient-centered medical home. We provide medical services, dental services, behavioral health, pharmacy, and other services, all in one place. Next slide, please. And so this project came about because we trained New Jersey's first group of community dental health coordinators. This is a position that did not exist in New Jersey until 2019, when we had our first group of staff members trained to do this job. And basically this involves patient navigation and case management on the dental side. We know that role has existed on the medical side for quite some time, and we know how important it is on the medical side, but there's been nothing similar in dental. And so we had the opportunity to train the first group of CDHCs in New Jersey, and we're in the process of starting a training program in collaboration with the American Dental Association to start training community dental health coordinators this summer, hopefully. Next slide, please. So this project, HPV project, was a perfect fit for this group, because as they finished their training, we were looking for a project for them to do. And the HPV vaccine rates in our center were low. It's not one of the federally mandated vaccines that we have to report on. We really have a high emphasis on quality improvement at our center, and we were very interested in improving the HPV vaccine rates. And again, when it's not required, people tend to pay less attention to it. So this was a great opportunity to put a group of folks together working on a project to help improve the rates of our HPV vaccinations. Next slide, please. And this was a perfect fit, again, because the vaccine schedule kind of fit with the dental recall, dental recare schedule. We tend to see our patients every 6 months, so the vaccines are administered 6 months apart, and then also, you know, if we miss them, they come back, you know, that hopefully will be back a year later. So we wanted to kind of take advantage of that vaccine schedule and, you know, integrate with medical and collaborate on getting those vaccines in place. Next slide, please. So we looked a little bit at our initial vaccine rates, and they varied by site. Some sites, you know, numbers were really bad, almost zero, depending on the age group we looked at. So again, this presented a great opportunity for us to work on a quality improvement project and improve vaccine rates in our center. Next slide, please. The project aim we set was to increase HPV vaccination rates by 10% by the end of the year. Again, with the understanding that this would be helping tremendously in reducing oral cancer rates. Next slide. And as the project developed, we wanted to make sure we understood that this impact that this team is having, you know, we want to be able to measure it and know that we could track the children. So we looked at a specific cohort of 900 patients that were both medical and dental patients. So we wanted to be able to track those children and see, once they've been referred from dental, what's happening to them on the medical side, and be able to track them and see if they're getting their vaccination rates. And in that initial group that we looked at, the vaccine rates were 12%. Next slide, please. So we developed our project aim, again, focusing on the process that we're going to be implementing, counseling the patients, giving them information about the vaccine in dental, giving them a referral, and tracking how many of these things we're doing, and then tracking the outcomes. So the outcome measure for us would be, you know, the numbers of vaccines that are being administered. So the process was, you know, what we were doing in dental, the education, the referral, and then on the outcomes end was tracking the vaccinations. Next slide, please. And so for the methodology, basically it was mostly the quality improvement processes that we have in place. We use the model for improvement at our center, the plan, do, study, act. So it's all about small changes, implementing small changes with small teams, introducing those changes, testing them out, see how they're working, and spreading to other sites once we know what we have is working. Another major component of this project was patient engagement, talking to the patients, engaging them, making sure we treat them respectfully and understand where they're coming from, and giving them information that they could use. So motivational interviewing was something that all the CDHCs were trained on. So that was also utilized with this project to interact and educate the patients. And also we looked at having the right educational materials and things that we could use. I will share another slide on that as well later on. And then data capture, how we're going to track the data, make sure that this process is working. And then ultimately we wanted to develop a dashboard that we could utilize on a regular basis to help us maintain the improvement that we established for the project. Next slide, please. So again, this presented us with a great opportunity to improve the integration and collaboration. On the medical side, we had the patient-centered medical home coordinators working with the CDHCs, partnering together to follow up on the patients, helping with scheduling, patient navigation, and making phone calls and following up and getting the patients in. We had frequent team meetings and regular check-ins, which were important drivers for this project. So we had those team leaders kind of meeting on a regular basis to follow up and review who needs to be called, who needs to be brought in. Training was a big part of this project. Initially, we used a lot of ADA training resources and train our staff. Some of it was virtual, some of it was in person, but what really helped us as we moved along with this project was collaborating with the Partnership for Maternal Child Health of Northern Jersey and the resources that they had available. We were able to train every site, our teams at every site, including the front desk, the medical assistants, dental assistants, the providers, so that we were all on the same page and everybody was providing consistent information and helping encourage patients to, parents to get the vaccines for their children. Next slide, please. So one of the tools we used early on was the PDSA log. So we had each team member track what they were doing as they tested various interactions with the patients. They recorded what they did, how the patients reacted, what was working, what wasn't working, what needed to be changed. Next slide, please. And we used, again, motivational interviewing, asking open-ended questions with the patients. We trained the staff to do that, chair side, looking at the right educational tools and providing information, again, in a respectful manner, not pushing the patients, too much or, not respecting their opinion. So that was a major component of the project as well. Next slide, please. Next slide. And then in terms of educational tools, we looked at various educational tools, and we thought we would create our own kind of assessment sheet. And as we looked at resources that were available from the ADA and other places, we found the Team Maureen materials, which was extremely helpful, was consistent with what we were trying to do. It had the oral cancer exam pictures right in the brochure, used simple language. It was available in English and Spanish, and it was available at no cost. So it was a great tool for us to use as we interacted with the patients. So we decided to just use that instead of creating our own, recreating the wheel and creating our own materials. Next slide, please. To capture the data, we use our electronic records, and we created a tab for structured data within the system. So every time the dental staff interacted with a parent and gave them information about the HPV vaccination and encouraged them to make the appointment, they recorded that interaction in ECW, which is our electronic record system, to track the interaction with the patient. Next slide, please. So again, we used smart codes to record the counseling and the information being given and the referral. Next slide. And once that information was recorded, we generated reports on a regular basis. So the staff, the CHCs, were looking at these reports, seeing who had their vaccine, who needed the second shot, who needed 3 shots, and who had none, and just kind of following up based on those reports. So they were either initially recording by hand who they interacted with, who needs follow-up. Then we were generating reports, and this was kind of all helping us develop what we needed to do so that we could build our dashboard ultimately. Next slide, please. So in terms of workflow, we learned a lot of things as we started this project. One of the major things we learned was to focus on oropharyngeal cancer. Patients were very interested in that. Initially there was a lot of concern among the staff over, talking about cervical cancer and other cancers and the reaction of the parents. But we found that it was better for us to stick to oropharyngeal cancer because that was, that was our business. That was what the patients were there for. They had more interest in oropharyngeal cancer. They in some cases, they had heard about HPV and cervical cancer. In other cases, they had heard nothing. And but in both cases, sharing information relating to oropharyngeal cancer was more interesting to the patients. That was kind of what we found. They were there for a reason, to see the dentist. They were concerned about their mouth, so that they were more receptive to a message about oropharyngeal cancer. We discovered that we couldn't just refer the patients directly to medical if they hadn't been there for a while. So part of our workflow was to schedule a follow-up visit, an exam visit for a physical with medical if the child hadn't been to medical for a while. So we kind of adjusted our workflow to make sure we schedule the patients for the right type of visit, and those who had their physical recently and could get the vaccine were scheduled directly to go in for their vaccine. Next slide, please. So like I mentioned, some of the lessons learned was that the parents were very interested in preventing cancer in their children. Oropharyngeal cancer, we found it best to focus on that in our discussion. We stressed to the parents the importance of getting the vaccine early. So our conversation focused on why it's important to get the vaccine as early as possible, that the vaccine was most effective if it was administered between age 9 and 12. That's the highest level of protection that it could afford the child. So it was easier to just kind of focus on our conversation on future cancer prevention and not so much on sex and the children being engaged in sexual activity, and more just on getting a vaccine as early as possible for these children so that they could get the optimal protection in the future. So we kind of focused on that, and it worked very well for us. Again, the Team Maureen brochures were very helpful. Having the close relationship between the PCMH and the CDHCs was very helpful, because people have to be able to communicate back and forth and understand what's happening with the patient, what kind of appointment they need, how to schedule their appointments, how to fit them in the medical provider schedule, and vice versa. And so these were some of the things that we learned through the process. Next slide, please. Some of the challenges early on included, figuring out how to collect the data, how to track the data. So it was initially a lot of tracking by hand, and then moving to spreadsheets, and so there was a lot of those challenges before we could ultimately develop our dashboard, which basically took the structured data from ECW, our electronic record, and put it into a Tableau, and it was much easier to filter. But initially, we had to do a lot of that by hand. We had to, again, train the staff. Getting everybody on the same page was extremely important because, again, a couple of years ago when we started, some of the providers, were following different recommendations. The AAP, encourages vaccination starting at 9. CDC says it could start at 9, but they recommend starting at 11, but they say it can start at 9. So there was a little bit of discrepancies between the providers. There was little misinformation even among the dental providers. So we had to work through that. Again, the partnership was extremely helpful in getting the trainings and getting trainings at all sites. So I would definitely encourage everybody to take advantage of that. It's a great resource that we have in New Jersey. So that that was one of the challenges we had to overcome, getting everybody on the same page early on. Sharing data was a big thing. So in addition to what we had in our system, we also needed to make sure whatever is in NJIS is getting transferred into our electronic records, and the child's vaccine records are kept up to date. So we had a lot of volunteers helping us with that effort. We have a group of AmeriCorps volunteers that helped us enter that information in the system on a regular basis. So that had be updated. Next slide, please. So ultimately, again, we created the dashboard. That was like the biggest driver for our project, because without doing, spreadsheets and hand recording things, we had a tool that, we could filter, that was being updated daily, so we could track, every patient, see who's coming in, who needs to be vaccinated, who's going to be in medical today, or this month, who's going to be in dental. And we could, set up alerts and know that when they're coming in, we need to either get them vaccinated or schedule them with the right provider to get their vaccine. So, it was easier for the CHCs to follow up. They made about, 15 phone calls a week. It's easier when you know who you have to target and exactly who you have to reach out to. Next slide, please. So this is just showing our canceling rates and how they increased as we started the project. So our CDHCs were trained, and their training ended, in July. So the numbers started dipping, and then we kind of started, we were struggling with keeping up the momentum. And then once we had the dashboard up and running, and we could share information with the team and show everybody how they're doing, the numbers started going up exponentially again later on in the year. Next slide, please. This is just a view of the dashboard. It had different tabs that you could click on, and then you could click on your site. You could filter your site, filter for the month, and again, once you click on that number, so if you see that there's patients coming in that are due for first or second vaccine, or third, if that's the case, then you could just click right on that number, and it will bring up the patient's information, and you could the staff could call the patient and follow up with them. Next slide, please. And so this is these were the outcomes. We were watching our vaccine rates in that group grow very quickly. Again, we were hoping for 10%, but we saw within a short period of time, it went from 12% to 31% to 36% in February, and then kind of COVID hit, and it was hard to maintain the momentum, and we had dental was shut down for a period of few months, but we still managed to finished the project in October with a 42% increase, 42% rate. So we had a significant increase, 30% increase in our vaccine rate, which we're very happy with. So we implemented these changes in our routine. Patients are regularly being given referrals to medical, and we're tracking those referrals. And one of the things I wanted to mention is that regardless, whether a dental provider has a connection with a medical provider and they could see what's happening and how many patients are getting vaccinated, I think we could all rest assured that it's very important for the dental provider to give this information to the patients and encourage the vaccination and talk about oropharyngeal cancer prevention, because patients are very receptive to it. And based on our experience, we were able to show that patients are following up, and you are saving lives potentially, and saving a lot of patients from suffering in the future and cancers. And oropharyngeal cancer is one of the hardest cancers for us to detect. It happens in the back third of the mouth, so it's often detected too late. So being able to prevent it like this is just a major major thing. It's a major opportunity for every dental provider to have a significant impact on patients' lives. So definitely want to recommend doing it. So even if you can't track what's happening to every patient, dental providers should be confident that this is extremely important to do. Next slide, please. Okay, so I think for us, the CDHCs were extremely important in helping push this project forward. Like I mentioned, we are hoping that we will start a CDHC training program in collaboration with the ADA this coming summer. I think they have the right skills and the right training to talk to the patients, the right way, help follow up, navigate the patient through the system, discover any challenges, any barriers that are in the way, and kind of help navigate through those. And I think that's the end of my portion. I think that's the next slide. Yep. So if there are any questions, I'd be happy to answer those.
Thank you so much, Dr. Wakim, for the presentation. And reminder to audience, we are open for the questions now. So we do have one or two questions. So the first question is, are the New Jersey dentists able to administer the HPV vaccine? And if not, do you know any of the states that administer HPV vaccine in the dental settings?
That's a great question. So New Jersey right now, we have an emergency order where dentists can help with COVID vaccination. And we cannot administer the HPV vaccine. We are trying to take advantage of the fact that we can administer COVID vaccine, and we're training a lot of our volunteers, and we have our volunteers engaged in helping with COVID vaccination, because we want to show that this is doable and this is safe. There is legislation, I think, making its way in the New Jersey system to approve having dentists vaccinate for HPV, flu, and any type of future pandemic. And we're hoping this will pass. I hope there's going to be support for that, because I think there's definitely a need for us to be engaged. Again, as far as HPV is concerned, the patient's right there. We're seeing them every 6 months. This makes perfect sense. So I really do hope that it passes. I think Oregon is one of the few states that I know of where dentists can administer vaccines, and I believe they could do both HPV and flu there. But hopefully more states will be thinking about it like New Jersey is.
Okay, thank you. That was very informative. And the second question is, when is the best time to discuss the HPV vaccine with parents, and who, in addition to the dentist, can be a part of this effort, like, for example, dental hygienist or anyone else?
Yeah, absolutely. dental assistants and the dentist, they could all be involved in this conversation. So the CDHCs that we trained, some of them were certified dental assistants, and we also had one dentist go through the program. So it's you know, any of the team members could have the conversation. I think it's important to start as early as possible. That was kind of what we learned, because again, you're focusing on optimal effect of the vaccine. You're focusing on getting it when it could be most effective, and that's like again the 9 to 12 window. So it makes the conversation much easier, and you know, I think it's something that any of the team members could do.
Thanks a lot. Many thanks to Dr. Greenstock and Dr. Wakim for this wonderful presentation and webinar. So a reminder to audience that you will be receiving a post-program evaluation within an hour after this webinar, and the certificates of completion will be sent via email and should be received within 2 weeks. And we also have more exciting professional educational programs coming up. A calendar of partnership upcoming virtual program can be found at www.partnershipmch.org under the Professional Education tab. We also offer on-demand recordings of many of our programs, which are listed there as well. Hope you can join us at our next educational event. Thank you, everyone. Thank you all the organizers and the presenters.
Thank you.